Okay. Hello and good evening, everyone. On behalf of the Indian Society of Hematology and Blood Transfusion, I invite you all for today's masterclass session. Over the last 1 month, we've had 3 wonderful sessions, and we are stepping into the 4th session today. And it gives me immense pleasure in welcoming today's faculty, Dr. Biju George. Dr. Biju George is a professor and head of the Hematology Department at Christian Medical College, Vellore. He was trained at CMC Vellore and in the Westmead Hospital in Australia. He has authored and co-authored hundreds of various articles in numerous international journals, and he is a member of various national as well as international boards. His areas of keen interest include bone marrow failure syndromes, MDS, transplantation, and post-transplant infections. He is a stalwart as far as the field of aplastic anemia and bone marrow failure syndrome in the country is concerned, and we are lucky to have him here with us today. And he will be talking on a very important, a very common yet very intriguing entity that we frequently encounter, both in the clinic as well as in the lab. The topic for today's session is going to be diagnostic approach to pancytopenia and the treatment options for aplastic anemia. Before we begin the session, let me just quickly remind all the participants that this will be a 1-hour session. We will have the talk for 45 minutes. Followed by discussion, question and answers for the next 15 minutes. So if you have any questions, feel free to type the questions in the chat box, and we will collect all the questions and have a discussion of all the questions together at the end. With that, I invite Dr. Biju George to start his presentation.
Thank you, Arun, for the introduction. I will just share my slides. I hope the slides are visible.
Yes, sir.
Yes, sir.
Okay. So when we look at the whole aspect of bone marrow failure syndromes, it's a group of disorders where a stem cell defect, which can either be a congenital or an acquired defect, results in the failure of one of more of the hemopoietic lineages. So these bone marrow failure syndromes can involve a single lineage or multiple lineages, and can either be congenital or acquired. And depending upon what lineage is involved, you can have inherited disorders and their acquired counterparts. So for example, if you look at pure red cell aplasia, Diamond-Blackfan anemia is the inherited disorder, pure red cell aplasia is the acquired disorder. Similarly, you have for neutropenia and thrombocytopenia, or you can have multiple lineages, and their inherited disorders would generally be Fanconi anemia and dyskeratosis congenita, while the acquired disorders would be aplastic anemia and myelodysplastic syndrome. Now, one of the important things to remember is that pancytopenia is not synonymous with aplastic anemia. Aplastic anemia is one of the important and probably one of the most frequent differential diagnosis in a patient with pancytopenia, but it need not be the only diagnosis. And that is why if you look at the left side, is this whole range of different diagnoses that can present with aplastic anemia. So one of the important things when we see somebody with pancytopenia is to do a marrow. And when you do a marrow, it can be two things. It can either be a hypocellular marrow or a cellular marrow. If it is hypocellular, then you're looking at acquired aplastic anemia. You could have, like I mentioned, some inherited aplastic anemia, especially Fanconi and dyskeratosis congenita, or you can have some types of myelodysplastic syndromes, for example, the hypoplastic MDS. But you also have a group of patients who may present with the cellular marrow. And there you're looking at MDS, PNH, myelofibrosis, subleukemic or aleukemic leukemias, bone marrow lymphomas, hairy cell leukemia. Importantly, things like SLE, vitamin B12 folate deficiency, they all can present. And very important in India is to remember hypersplenism, in secondary to say chronic liver disease or a chronic malaria, and that can also present with pancytopenia. Now, if we do find a hypocellular marrow, and where there's aplastic anemia, the next important thing is to see whether it's secondary or primary. So if you look at right at the bottom, these are the causes of inherited aplastic anemia, but then you have also acquired aplastic anemia, which could again be primary or secondary. And usually secondary means secondary to irradiation, secondary to drugs, which could either be a cytotoxic effect that is dose dependent or idiosyncratic reaction, or could be viral induced aplastic anemia. But in majority of the patients, you do not find a preceding etiology, and that is where you come to this whole group of what is called as idiopathic aplastic anemia, which we believe is immune in origin. So when we talk about aplastic anemia, one of the important things to remember, persons we remember is Paul Ehrlich, who won the Nobel Prize in 1908, but that was not for aplastic anemia, but he was one of the first persons to describe a person with aplastic anemia. This was in a lady who was pregnant. Now, we need to remember that aplastic anemia actually presents with non-specific symptoms. They present with features such as hematopoietic failure. So you can get a transfusion-dependent anemia, you can get bleeding because of thrombocytopenia, and you can get recurrent infections and fever related to the neutropenia. This could be a combination of all three or one or two lineages, depending upon the degree of hematopoietic failure. The important thing when we examine a patient with aplastic anemia is to look for organomegaly and lymphadenopathy. Now, if we do find lymph nodes, or if we do find a liver or spleen, we are reasonably sure that it cannot be aplastic anemia and there is some other infective or infiltrative disorder that is the cause of the pancytopenia. The peripheral blood is actually very bland. You would get only a pancytopenia with neutropenia, and you need a marrow for diagnosis. So if you look on top, you will see a well hemoglobinized red cells with neutrophils in the peripheral blood, and you see these nice platelets which are present throughout. But when you look at a peripheral smear of somebody with aplastic anemia, you will see anemic red cells, you would see lymphocytes more than neutrophils, and you would hardly see any platelets. Now that the number of platelets and the number of neutrophils that you see will depend upon how severe the disease is. But that is all you can make out. Of course, you would look at the peripheral smear to look for any abnormal cells, and if that is present, your thought process will go in a different way in terms of looking for an infiltrative disorder. Even in a trophine, when you look, on the right side is a normal marrow trophine, which usually consists of fat spaces interspersed with hematopoietic tissue. Now, when all this hematopoietic tissue disappears, what you get as on the left side is only fat spaces with occasional areas of hematopoiesis that are present. And this fatty marrow is what is usually seen in a bone marrow, in a aplastic anemia bone marrow trophine. So we need to remember that when we're looking at a diagnosis of aplastic anemia, it is more of a diagnosis of exclusion rather than inclusion. That means we have ruled out, we have made sure that the cellularity is low, we have ruled out all abnormal cells, we have ruled out fibrosis, other infiltrations, and then we think that it could be aplastic anemia. Now, what happens in terms of the pathophysiology? Like we mentioned, the cellular marrow has been replaced by fat cells. What is classical is the marked reduction in stem cells. So your CD34 positive cells are markedly reduced. There's a reduction in the colony-forming progenitor cells. So both your granulocyte macrophage, your erythroid, megakaryocyte, all these progenitors are reduced and they are not responsive to high levels of growth factor. Long-term colony-initiating cells are absent, And there is also now in some data to suggest that the stroma may also be defective in aplastic anemia. Now, the stem cell and the progenitor cell compartment is what is affected in aplastic anemia, which leads to complete stem cell exhaustion. Now, this could be either direct effect of viruses, drugs, chemicals onto this compartment, or the viruses can induce immune processes, which again leads to this destruction. And what has been so elegantly described by Neil Young is the fact that the major cell that seems to affect are the cytotoxic T cells. These cytotoxic T cells express Fas ligands, they secrete interferon gamma. There's a massive expansion of these T cell clones, and these attack the hematopoietic cells that leads to destruction of the hematopoietic stem cells. Now, what is also being clear is that there is more to the biology of aplastic anemia. Now, telomeres are end caps that protect the chromosome normally in all of us. And in the normal process of aging, with each cell division, the telomeres actually shorten till it completely goes. When it completely goes, the telomere, the cell division actually stops and the cell dies. That is the normal process of aging. Now, what is also known is that this telomere is controlled by an enzyme called as telomerase, and both the telomere and the telomerase are coded for by a group of on chromosome 6 by a complex of genes, and so mutations in these genes can actually cause rapid telomere shortening. And studies have shown that in roughly 30 to 50% of patients, the telomeres are short. So this is a study from about 20 years back where they looked at telomere length, and they showed that this is normal persons. These are people with idiopathic aplastic anemia. They have shorter telomeres, and congenital forms have even shorter telomeres. Now, among these patients who have telomere shortening, in about 10%, they may have mutations in the TERT or TERT gene. Now, why is it important? This is important because beyond the standard inherited bone marrow failures such as Fanconi and dyskeratosis congenita, there are also other genes which may be mutated. And if there are genetic mutations that lead to aplastic anemia, they are no longer immune aplastic anemia, but they are congenital bone marrow failure syndromes. And these mutations in TERT and TERT are the ones which have brought out this whole biology of what is called as telomere-based syndromes. Now, this is the entire complex of TERT, TERK, discarin, which code for a number of enzymes and polymorphisms, which can actually then lead on to aplastic anemia. And generally, what you would see is a combination of aplastic anemia plus minus pulmonary or liver fibrosis and other hematological malignancies. It doesn't happen all in the same patient, but it happens in the same family across generations. So you may have a patient with aplastic anemia. They may have had an aunt who died of AML. They may have had a close relative who's got liver fibrosis or pulmonary fibrosis. And if you see this history of hematological failure, hematological malignancy, lung or liver fibrosis, early premature graying of hair, then you have to worry that this is probably a telomere-based mutation, and so we need to search for this. Now, once we make a diagnosis of aplastic anemia, what is important is to assess its severity, and the severity is based upon the bone marrow cellularity and the counts. So you have to have a bone marrow cellularity more than 25%, and 2 out of 3 you look for an ANC less than 500, platelets less than 20, reticulocyte count less than 20,000. Now this varies from different definitions. Some even go up to 60. This is the old Kamita criteria. If you have 2 out of these 3, then you call it severe aplastic anemia. If the neutrophil count is less than 200, then it becomes very severe. And if it doesn't fulfill this criteria, then it becomes non-severe aplastic anemia. Now, why is it important to make this distinction? It is important because severe and very severe aplastic anemia, 90% will die in the first year without treatment. So we need to remember, unless they get proper treatment, 90% will die within 1 year of diagnosis. And that is the reason why it's very important for us to think in terms of rapidly treating people with severe and very severe aplastic anemia. So what about treatment? I think before we think about treatment, first and foremost, it is very important to make sure we had an accurate diagnosis. When a child with aplastic anemia, one of the important things is to ask this history, did this patient receive a course of steroids? Because then the worry is, could this actually be a partially treated ALL? And we have learned this from our own experience in the past, where we have, because what usually happens in an ALL is, if you give them steroids, they go through a phase where the blasts disappear, but the hematopoietic cells don't recover. And at that time, if you do a bone marrow, you will find a marrow empty, exactly like aplastic anemia. So for us, if we find that the patient has received reasonable steroids, we would just wait with supports for at least a month. Because if it is aplastic anemia, you can be sure that within a month, the blasts will come back. If it doesn't come back, then we can be reasonably sure that it may not be aplastic anemia. One of the important things is to make sure that we do a biopsy. Sometimes we get a scanty aspirate and we call it aplastic. No, we have to show an empty marrow, because you can pick up infiltration with leukemia, lymphoma, myelofibrosis on a trophine biopsy, which you may not pick up on an aspirate. In a child or somebody who's got abnormalities, we should look at stress cytogenetics, and conventional karyotyping or cytogenetics may be useful in hypoplastic MDS. And of course, we screen all these patients for PNH. So what are some of the additional tests that we need? And I will talk about stress, PNH, conventional karyotyping, and next generation sequencing. Now, this is basically to look for inherited bone marrow failures. Now, we know that in Fanconi, for example, there's a problem in DNA repair. So if you expose lymphocytes to clastogenic agents like that mitomycin C or diethoxybutane, and then when you rest them, they will not join back together properly. And that is where you see your radial forms, your ring forms, multiple different bizarre shapes. And then you score it. If you get a score above 40, it is consistent with Fanconi anemia. Now, the age limit of when you would test varies from group to group. We would do it only below the age of 30, or beyond that if they have some features suggestive of Fanconi anemia. The important thing to remember is that the stress cytogenetics is not 100% foolproof. In about 10 to 15%, because of mosaicism, because of techniques, you may not get a high score. That is why if you have a clinical phenotype of Fanconi and the stress comes negative, we have to go ahead with other tests to basically be sure that you're dealing with Fanconi anemia. In adults with acquired aplastic anemia, we need to look for PNH. Now, this can be done by either flow cytometry, where you look for CD55 or 59 negativity. Importantly, about 40–50% of patients with aplastic may have a small clone. Why is it important? Because there are some studies that have suggested that if you have a small clone, you may do better with ATG, but there are other studies which have shown that it is not true. What's more recently done is FLAIR, and that is more significant in picking up clones, even very small size of clones. Should we do conventional karyotyping? Now, we need to know that 10 to 20% of patients with aplastic anemia will show trisomy 8. Monosomy 7 may occasionally be seen. There is some data to suggest that it may show increased risk of transformation, but people are more worried when you see a monosomy 7 about whether it's actually a hypoplastic MDS rather than aplastic anemia. So the majority view is that do not do karyotyping. It doesn't add to what you're going to do. What is important now is next generation sequencing to look for identifiable genetic or somatic mutations. And we are identifying more children with genetic disorders, which has important implications for both stem cell transplant and immunosuppressive therapy. I will talk about that later. So it's important to do NGS. Its importance of doing MGS in adults is still not clear. There are some studies which have looked at AXXL, DNMT3A, RUNX1, TP53, shown that if they are present, they are associated with poor response to immunosuppressive therapy, or BCOR and PGA gene is associated with good response, but these have not been validated in prospective studies. Now, what is the kind of treatment that you can do? I think two important things. When soon as you get a patient, I think supportive treatment is important. Packed cell transfusions to keep the hemoglobin above 7. Platelet transfusions, you have to be careful. Patient is bleeding, febrile, yes. But otherwise, you don't have to go by the numbers, because the more you give platelets, the more you are going to alloimmunize. And prompt treatment of infection, and then definitive would be measures to constitute hematopoiesis. So definitive therapy consists of stem cell transplantation, then of course immunosuppressive therapy and the use of androgens. Now you would have seen various protocols in terms of how people, children and adults would be managed. Essentially, the bottom line is, if you look at children, if they have a matched sibling, no doubt this is the way to go. Now, if they don't have a matched sibling, it's a question of immunosuppressive therapy or alternate donor transplantation. In adults, the cutoffs vary from group to group. Some people would say 40. At our center, it is 50. If you go to Seattle, it is 60, where they would offer an allogenic transplant if there is a matched sibling donor only. For those who do not have a donor or those who are older, you would consider immunosuppressive therapy and consider other transplants only if they fail. So stem cell transplant is probably the best treatment for somebody who's less than 50. I think it's very important, if you've decided on transplant, to take them quickly. So organize HLA typing as soon as possible, irradiate all blood products, and avoid transfusions from first-degree relatives. Now, this is data from the CIBMTR showing what are the outcomes of transplant. So it's about 85% when you're dealing with somebody less than 20 years, 70% when you're dealing with more than 20 years. This is with sibling donors, and it's about 50 to 60% with unrelated donors. Now, why are these important? These are important only because they are benchmarks against which you can evaluate your own transplant program and see how much you can reach in terms of outcomes. So we started transplants in 86, and we started transplants for aplastic anemia in 1990. We have done a total of about 2,700 transplants till December. We do about 170 allogenic and about 80 autologous per year. So it's roughly about 250 transplants a year. And it is the third highest indication for transplant at our center after thalassemia and AML. The third highest group is aplastic anemia. So this is our transplant unit. We've got about 18 beds, single rooms, HEPA filter, where the patients stay for 3 to 4 weeks till they recover from the transplant process. So we've done about 434 transplants for aplastic anemia, about 350 siblings matched donors, 28 MUDs and 60 haplos. We have certainly evolved in terms of the protocol that we use. We earlier used to use the cyclophosphamide ATG conditioning, which was the standard protocol around the world. Now, because we found higher rejection rates, we have slowly evolved. And for the last 18 years, we've been using a combination of fludarabine with cyclophosphamide. And early last year, we actually published data on about 212 patients who were transplanted with fludarabine and cyclophosphamide. We used peripheral blood stem cells. They were with very low rejection rates of 1.8%. Acute and chronic GVHD is still high, about 27 and 40%. Importantly, the overall survival is about 75%. So 3/4 of patients who undergo a transplant can be cured if they have a sibling donor. Now, it is about 80.6 who are less than 20 years, 74.5, 20 to 40, and about 60% when you're looking at more than 40 years of age. And importantly, if you took up the patient early for transplant, and a low risk means less than 20 transfusions, transplant within 3 months, without active infection, bleeding, or exposure to ATG, we actually have a 93% chance of long-term cure. And that is why the reason why I say that we have to ensure that if there is a transplant candidate, we take them up quickly for a transplant. Now, for those who are old, that for us, it's usually a 50 cutoff, or those who are less than 50 but do not have a sibling donor, or those who have non-severe, what we offer is immunosuppressive therapy. And the common is ATG or ALG. And basically, this is hyperimmune globulin preparation made from plasma of either rabbits or horses that have been immunized with human thymocytes or T cells. Now, what is available is both horse and rabbit. AdGam was what was available. Now it's gone out of the market because of COVID. What is available is Thymogam from Bharat Serum, which is equine, or Thymoglobulin from Genzyme, Sanofi now, which is rabbit ATG. Generally, the AdGam dose is 40 milligram per kg for 4 days. Thymoglobulin is 3.5 milligram per kg for 5 days. Now remember, this is anti-human immunoglobulin produced in an animal. So you are going to get serum sickness. So you would give about 2 weeks of steroids to prevent serum sickness. And generally, you add ATG to cyclosporin. Data from around the world, roughly about 60 to 70% would respond. But importantly, on follow-up, about 20% will relapse and about 10% will have clonal evolution to MDS, AML, or PNH. There have always been a debate between horse versus rabbit, but the randomized trials from Neil Young's group at the NIH clearly showed that the response of horse ATG, about 60%, was superior to the response with rabbit ATG. Now, there have been other studies. This is the Pethima group showing that there is no difference between horse and rabbit, except that early mortality due to infections was higher with rabbit ATG. The EBMT also did a study looking at rabbit ATG and comparing it with the historical cohort, showing no difference. But important to remember that the Neil Young study is the only randomized trial. Now, what is our own experience? We have been using only horse. Earlier, we used Pasteur Mario ALG. And then now we have been using Pfizer. In general, roughly about 70% among non-severe, 60% among severe, and 42% among very severe show a response to ATG therapy. Now, what is clearly seen is that children do poorly, only 37% response, while it's between 60 to 65% response between 16 years and higher. And the oldest patient that we have given ATG is actually 74 years of age. Now, however, both treatments are still costly. We are looking at a sibling donor about 14 lakhs. We are looking ATG cyclosporin about 10 lakhs. Now it's come down because of the Bharat serum, but it's still out of reach for a lot of patients. So what can we do for patients who cannot afford this? One of the things is to give cyclosporin alone. It is an immunosuppressive drug which causes inhibits transcription by IL-2 and interferon gamma. Generally, you give 5 to 10 milligram per kg for 3 to 6 months. You have to monitor because they have renal toxicity, hypertension, gum hypertrophy, hypertrichosis. But this is our own data, roughly about 300 patients. It shows very good response in non-severe aplastic anemia, about 70%, but it's only about 30% in severe and very severe. Most of them are partial responses, but at least they become transfusion independent. Androgens, danazol, stanozolol started as a poor man's option because it costs 2,000-3,000 a month. Response seen in about 20 to 30%, mainly in mild disease. It is coming up more because there is data to suggest in those who have telomere disorders, danazol may actually be useful not only for the aplastic anemia, but even for the pulmonary fibrosis. You need to watch for hepatic toxicity. So what is the new kid on the block in aplastic anemia? Is Revolade or Eltrombopag. And the initial data from, again, Neil Young's group suggested that in using it as monotherapy, in those who have failed at least 2 to 3 lines of therapy, you see responses 40%. Now, what is important is to remember that these responses were seen only in patients who received 150 milligrams per day, not at lower doses. So the doses that we use for ITP cannot be used in this group of patients. More increasing the dose higher only increase toxicity without improvement in response. So the question is, can we go beyond ATG and cyclosporin? So there have been studies which have looked at adding on sirolimus, no use, adding on mycophenolate, no use, adding on danazol, but none of them resulted in improvement in outcomes. Now, one of the things that has been seen is that although in aplastic anemia, TPO levels are automatically high, which means that TPO agonist should not work in aplastic anemia, the TPO receptor is seen at multiple levels. So at the progenitor level, both the granulocyte macrophage level and at the megakaryocyte level. So it's at multiple lineage levels that you can actually see the use of TPO. And that is the reason why the TPO agonists work in aplastic anemia. So this was the seminal study done from NIH looking at ATG, cyclosporin plus Eltrombopag. There are 3 cohorts giving it for 6 months, 3 months, and starting from day 1 for 6 months. And very importantly, overall responses went up to almost 80 to 90%. This is in contrast to the 60 to 65% that you are getting with ATG and cyclosporin. They showed that bone marrow cellularity improved, and importantly, the CD34 cells quantity in those who had marrows also showed improvement. There have been studies also this is from the MD Anderson, showing that there was no difference between immunosuppressive therapy versus immunosuppressive therapy and Eltrombopag. But what recently has come out this year is the RACE trial from the Europeans, where they have compared ADGAM with cyclosporin versus ADGAM with cyclosporin with Eltrombopag, with the primary endpoint being hematological complete response at 3 months, and showing that when you use triple therapy, it was 22% versus 10%, which was very significant. So triple therapy has actually become standard of care. We have used it in about 25 patients, and we have seen responses in about 85%. Problem, you are adding now a further 6 to 8 lakhs to the cost when you are giving Eltrombopag at 150 milligram per day for 6 months. So how do we keep moving further? So like I mentioned, one of the problems with the bone marrow transplant, which we described, was GVHD and chronic GVHD of 40%. So we actually took a clue from the post-transplant cyclophosphamide, which was being used in haploidentical transplants to see whether we can use it in aplastic anemia. And this was we published it in about 2018, where we used fludarabine, cyclophosphamide, PBSC, and only 2 doses of PTCY on day 3, day 4, with no other immunosuppression after that. We compared it with a historical cohort, and essentially we managed to reduce your chronic GVHD to 22% as compared to the 50 to 60% that we were having earlier. Importantly, about 50% did not need any further immunosuppression after the 2 doses, which means that 1 year of cyclosporin cost could actually be saved. We have now moved forward and we have started a multi-center trial comparing cyclosporin methotrexate versus PTCY for transplant. If any of you are interested, you can please contact me. We have been studying donor telomere length, and this is a publication in BGH last year, where we looked at about 163 patients who underwent matched sibling donor transplants. And we have shown that if the donor telomere length was long, irrespective of patient telomere length, they actually did better as compared to shorter donor telomere lengths. We are hoping to do a larger study involving multiple centers from India. We need to collect data, and so the aplastic anemia registry has been formed. There are about 9 hospitals here, and another 5 more are joining in. We are hoping that we can capture more data to see what is the outcomes of different centers from across the country. Now, because of a poor response with immunosuppressive therapy in children, one of the things we looked at was to look and see, are we missing out on other mutations? So we looked at NGS in about 121, and we have a large gene panel that we look at in patients with aplastic anemia less than 40. And importantly, in these children who are less than 5 years, 23% had a mutation, mainly in CMIPL, TERT, ARTEL, TNF2, various bone marrow. So these are all actually bone marrow failure syndromes which are inherited rather than it being immune. So over a period of time, we have decided to take up smaller children directly for transplant, without even those who do not have a matched sibling, to take them up for either an unrelated donor or a haploidentical transplant. So we have done about 29 transplants in 25 children. In those who did not have active infection, the 4 had a mud transplant, 21 had a haplo, and importantly, about 76% are alive and well at 12 months, which is far better than what we were getting with ATG. So I will conclude by saying aplastic anemia is a serious hematological disorder in India with high morbidity to both the patient as well as the family because of the costs involved in treatment. Stem cell transplant and immunosuppressive therapy are associated with reasonable outcomes, but only about 40% can afford this high-end treatment. We need to identify children who have inherited aplastic anemia and explore the presence of an immune signature that will tell us who may benefit from ATG and in whom ATG may actually be wasted, the whole money, and they may actually be candidates for an alternate donor transplant. Of course, we need to explore the use of cyclosporin, danazol, and generic TPA analogs further, because that will be a cost-effective option for anybody in India. With this, I will stop and I will be happy to take questions. Thank you.
Well, thank you, sir, for that enlightening talk. I'm sure all the participants would have benefited from the overview that you gave for pancytopenia, the approach to the various differentials, as well as the different treatment options for aplastic anemia. As of now, I don't see any questions in the chat box. So participants, if you have any questions, please do put them in the chat box. Meanwhile, probably I'll ask maybe 1 or 2 questions. So you briefly mentioned about the use of NGS now for the diagnosis of bone marrow failure syndrome. So can you just elaborate us how that has like modified your approach to the diagnosis or helps in making treatment decisions as far as aplastic anemia and BMFS is concerned?
So in children, because of the study that we did and where we found mutations. So we have started looking for mutations in all children with aplastic anemia. Now, how does this help us? It helps us in multiple ways. One, if you have a patient who's got an inherited bone marrow failure syndrome, there is no point spending money on cyclosporin or ATG because it will just not work. Two, if we find an inherited mutation and there is a sibling donor, it is important to make sure that the sibling donor also is not carrying the same mutation, because then you cannot. And we've had 1 or 2 patients where we found a patient who had a c-MIPL mutation. There was a matched donor. Donor is asymptomatic but has the same mutation. So people can present at different age groups even though they have an inherited bone marrow failure. And if we don't pick it up, we are giving the same disease back to the patient. Third, there are certain diseases. So for example, the c-MIPL mutations, it is described in literature that they have a higher incidence of graft failure after a transplant. So we have to modify our conditioning protocols to try and reduce this period of graft failure. So in multiple ways, it helps us in terms of distinguishing inherited from the acquired bone marrow failures.
Yeah, I see a few questions in the chat box. First one is from Dr. Alpesh. He has asked why there is no EMH in aplastic anemia. So I presume it's extramedullary hematopoiesis.
So that is because the bone marrow, when there is failure, it does not send signals out, or all your cytokines are actually reduced. So it does not send signals out for extramedullary hematopoiesis to occur as what you would see with thalassemia or with myelofibrosis. And that is the reason why you don't get hepatomegaly or a splenomegaly in aplastic anemia.
The next question is from Dr. CR, and he has asked, what is the role of prophylactic antibiotics in severe aplastic anemia?
It's a difficult question because I think it depends from country to country. If you look at British recommendations, they would use fluoroquinolone prophylaxis. We see a much higher incidence of MDR bacteremia in our patients with neutropenia. So we are not sure whether the use of prophylaxis will actually worsen it. And that is why we generally do not use prophylactic strategies in patients with severe aplastic anemia.
More questions are coming in. Dr. Raj has asked how late inherited aplastic anemia can present.
So generally, it depends again from mutation to mutation. I've had patients with some of the mutations like GATA1 who have presented at 30, 40 years of age, but they are the ones who present with warts and aplastic anemia. Most of the aplastic anemia tend to present in the younger age group. If they are in the older age group, many of them tend to have telltale signs. So we've had Fanconi who presents at 30, 35, but you have one look at him, you know it's a Fanconi which has been missed for so long. So the older ones will find, you will find some dysmorphism, some other abnormalities where you would suspect a inherited marrow failure.
Another question from Dr. Siaram. How to deal with failure of stress cytogenetics test due to poor cell count?
Yeah, so the options are you can do a skin biopsy and then do a skin fibroblast culture, and on that either do a stress or a FANG D2 ubiquitination. Now, I think most people find it much easier to just send off an NGS that will actually look for all the FANG mutations, and that will tell you the report in terms of that.
Another question from Dr. Alpesh. The germline mutations that you discussed, they are more common in acquired aplastic or in the inherited group?
So once we make them germline mutations, they automatically, they were called acquired because we couldn't find anything earlier. But once we find these mutations, they straight away push them out from the acquired aplastic into the inherited group.
The next question is from Dr. Chandramouli. How do you differentiate between aplastic anemia and hypocellular MDS?
So sometimes it's very difficult, but what are the things that we would look for? we would if you're a good pathologist, you should be able to pick up megakaryocytic dysplasia. But when you are a severely hypocellular marrow, even that may not be there. Then we would rely on the presence of is there increase in reticulin content? And we would get a CD34 staining done. Generally, in a hyperplastic MDS, that's normal to increase CD34, while in an aplastic, it's usually absent. These are the two features that we would look at morphologically to try and distinguish aplastic anemia from MDS.
And how important is it to make that distinction between the two?
It is important because even in terms of response to transplant is the same. It doesn't matter. But in terms of immunosuppressive therapy, they do not do as well with ATG as compared to aplastic anemia. So in terms of the prognosis, it matters. And we need to remember in a hypoplastic MDS, especially if they have a monosomy 7, they are at a higher risk of transformation to AML.
The next question is from Dr. Savitri Singh. At times, marrow biopsy may not show a aplastic picture, but on FUC, I'm not really sure.
Biopsy,
okay, yeah. Biopsy, it is clear aplastic. If history of steroid mentioned, do we need the biopsy to ascertain aplastic anemia? Or
So two things. So one is when we do a marrow, we should do an aspirate and biopsy because sometimes the aspirate may be dilute, but the biopsy may pick up immature cells. But if both are negative, but you have had a strong history of steroids being given for say 2 weeks, 3 weeks, then we generally would wait for 1 month. During that period, just transfuse and wait and repeat a bone marrow again after 4 to 6 weeks. If it was an acute leukemia, which had all cleared up because of the steroids, they definitely will come back in 4 to 6 weeks' time. And that will give you a clearer diagnosis whether you are actually dealing with ALL or whether you are actually dealing with aplastic anemia.
Next question from Dr. Siaram. Isolated erythropenia, pure red cell aplasia, how do you manage it medically?
Yeah, so I think whether you're dealing with the congenital, which is the Diamond-Blackfan anemia, or the adult variant, the first line of therapy is steroids. In a DBA, 60 to 70% response. In an adult PRCA, about 50% response. Now, those who fail, then in a DBA, you would go for an allogeneic transplant. In adults, because it's immune in origin, you can try Azoran, you can try cyclosporin, you can try mycophenolate, and generally, with each of the drugs, there is about a 40 to 50% response.
Another question from Dr. Savitri Singh. How many percentage of aplastic anemia patients have PNH clones?
So it depends upon what test you use. So when we were initially using the flow cytometry looking for just the 55, 59, I think the data was about 20 to 30%. Now, when we were using a more sensitive thing like FLAIR, it's picking up more. And so it has gone up to 40%. But what people are looking is to see, does the clone size matter in terms of the response? Whether a small clone does better than a bigger clone, we are not sure. We are waiting to see. And does the clone size predict who will have clonal evolution to PNH down the line is something people are looking at.
Yeah, I think essentially it comes down to the sensitivity of the assay, what percentage of cases we pick up, because invariably a lot of cases are going to have a very small PNH percentage. The next question from Dr. Harshini, how long we need to give irradiated blood products after ATG?
So we would generally give it for about 6 months, although I think some of the recommendations are even up to a year, but we would generally give irradiated blood products for at least 6 months after the administration of ATG.
The next question is from Dr. Raj. What are the common mimickers of aplastic anemia other than ALL that you commonly encounter?
So it depends from childhood to adults. So in the adults, MDS is something which is again very commonly seen in India, especially the hypoplastic MDS variety. We have had a few patients who've got, when you especially have hairy cell leukemia or a low-grade lymphoma involving the marrow, we have had a marrow which is aplastic or scandy on an aspirate, but we pick it up on the trophite. Generally, in a child, most of the time it is because you've not been able to get an adequate aspirate, and that is commonly seen with any infiltrative disorder. So pediatric MDS, the AMLs, amegakaryocytic leukemia, which is AML M7, which is more commonly seen in children, would be the areas where you would see.
The next question from Dr. Sierram: criteria for good bone marrow biopsy, diagnostic bone marrow biopsy to make the correct diagnosis.
So I think you need to make sure you have at least a 1 to 2 centimeter piece with at least cortical bone. You have to make sure there is cancellous cortical bone at least of a centimeter. And generally what they say is when you cut and have a look at a section, you should have at least 4 to 5 sections which are adequately represented.
Next question from Dr. Alpesh. Yeah, it's an important question that we frequently encounter in the lab as well. So he has asked hypocellular marrow without morphological dysplasia, but with MDS-related cytogenetic abnormalities. Would you label them as aplastic anemia or hypoplastic MDS, and how the management will differ?
Yeah, so it is difficult because so many of these cytogenetic abnormalities which you can see in MDS are also seen in aplastic anemia. So a 13q, a 20 deletion, trisomy 8, even a monosomy 7 can be seen. Traditionally, you would, if there was a specific mutation, especially monosomy 7, you would try to label them as hypoplastic MDS rather than aplastic anemia. Now, treatment-wise, does it differ? In some situations, yes, and some no, and I'll qualify that statement. If somebody had a hypoplastic MDS with a monosomy 7, you definitely wouldn't consider going for ATG therapy. We would, if there's no match sibling, we would consider alternate donor transplant. If it is not a monosomy 7, in the rest of it, it is a question of prognosis in terms of how many are likely to respond and how many are likely to relapse. So you may actually can't do the same therapy. It is just that the outcomes may be different.
Dr. Raj has asked, can we get the recorded links? Yes, Dr. Raj, I presume after a few days, all the talks recordings will be uploaded in the ISHBT website. You can just log in and you can view the recordings anytime at your convenience. Next question from Dr. Harshini. If one had an anaphylaxis with ATG, should we avoid giving it?
It's a difficult question. I think it depends upon what kind of anaphylaxis is. So just 1 week back, we had a patient in the ward who had ATG, developed hypotension. Then we waited for 1 hour, recovered. What do? We decided we will challenge again. But for precaution's sake, we shifted the patient to the ICU. So we did it under most closely monitored circumstances. And he received 3 days of ATG without any problems beyond that. Now, if somebody became very bad, hypoxic, required intubation or anything like that, we definitely would say no more ATG. Now, one of the important things to remember is this 40 milligrams into 4 days is not based on any scientific data. And we had a recent conversation in the bone marrow failure meeting, which we held 3 weeks back, because that's what Neil Young also said. This is not scientific. This dose was based upon convenience of the vial sizes that came. So there is data on using lower dose. There are patients who had only 1 dose, had developed problems like this, then got cyclosporin and improved. So just because you have given 1 dose does not necessarily mean, I think the first most important is do no harm. So you have to be careful about giving it. More controlled circumstances, conditions, you can give it. But if you find that the patient is developing a reaction again, I think best to stop it and just go to cyclosporin.
I think that's No, we have a couple more questions. I think the participants are not ready to leave you yet. The next question is maximum permissible interval between the diagnosis of severe aplastic anemia and the ATG used to be effective.
I don't think there's anything like that. Generally, the data is that if you are able to give it within 3 months, you have the best effect. As you go longer, the percentage of people who would respond would come down. So if you ask what is ideal time, I would say within 3 months of diagnosis. That is where you would get your best effect.
The next question, any transfusion cutoff for platelets and packed RBCs?
Yeah, so I think it varies from place to place. For us, generally, packed red cells, we would give only if the hemoglobin is less than 7. Like I mentioned, the platelets, we generally would not give based upon just the platelet count alone, even if it's less than 10. If it is going down to 1 or 2, we may give, but otherwise it's basically based upon is there presence of bleeding, does this patient require a packed cell transfusion, is there any fever? If that is there, we would give a transfusion. Sometimes you have these patients who have not responded at all and are sitting with 10,000 platelet count. You don't need to keep giving them platelets every day. Of course, they have to be monitored very regularly. They have to be close to a place where they would come in immediately if there is bleeding. But the more you transfuse, the more you're likely to alloimmunize.
Another important question that we encounter every now and then. Can we get Fanconi without the phenotypic features?
Yes, we can get Fanconi without the phenotypic features in about 10 to 15%. But many of the times it's because we are looking for obvious features. We have not looked for things just like short stature. We have not looked for something like low set ears. These are all minor. The ones who come with skeletal abnormalities, thumb abnormalities are on the lower side. But if you look for facial abnormalities, you look for a high arched palate, short stature, you are likely to pick up more.
I don't see any more questions. I think we have covered all the questions. Thank you so much, sir, for taking the time for this wonderful talk and for patiently answering all the questions. And an equal thanks to all the participants as well for making it such an interactive Q&A session. I mean, honestly, we've got more questions than we actually anticipated. And thank you all for those who attended and those who asked all those invaluable questions. I think with that, we'll wind up the session.
Thank you so much, Abed. It was lovely to get so many questions for a talk. So thank you all for listening and asking questions.
Thank you, sir. With that, we'll wind up the session. So good night, everybody.
Thank you, Arun sir. Thank you, Biju sir.
Okay, bye.
Thank you, Praveen.
Thank you, sir.